This is the third debate in the Lansdowne Question Time public debate series. The topic was NHS more or less, and there was strong representation from both the people who have offered services within the NHS and those who have received the services provided. The panel consisted of Stephen Coleman, a registered mental health nurse, who has worked in Worcestershire for 5 years and spent 2 years as Director of Operations for Worcestershire Health and Care NHS Trust. Dr Carl Elson, Chief Clinical Officer for NHS South Worcestershire Clinical Commissioning Group, who has 20 years of experience as a local GP. Peter Pinfield, Chairman of Healthwatch Worcestershire, who has been active in Worcestershire's health and social care for over 30 years and is currently a mental health associate manager and a member of the Learning Disability Partnership Board. And Sarah Smith, Director of Strategy, Planning and Improvement at Worcestershire Acute Hospitals NHS Trust, who has spent 10 years in various other supporting roles in the NHS in the hospital and community sectors. The chair for the evening was the Reverend Mary Austin, who has for 10 years been Superintendent Minister in Kidderminster and Stourport. Each of the panellists gives a short introduction before questions are submitted by the audience and then responded to by the panellists, with the possibility for more members of the audience to share their own views.
So I think I will start on my left, Sarah. I didn't actually warn them what order we would go in here, so I hope you're all right being dropped on like that. So I'm going to invite each one of our panel just to speak for about 5 minutes. Thank you.
Thank you very much, Mary. Good evening, everyone. My name's Sarah Smith. I'm Director of Strategy, Planning and Improvement at Worcester Acute Hospitals Trust. Worcester Hospitals, as you know, I'm sure you know, is one trust that operates on 3 hospital sites. But we do also work in some of the community hospitals and in some of the GP practices across Worcestershire. Hospitals define the NHS for many members of the public. But of course, they're not all that the NHS is about, and I'm sure my other panel members will agree vociferously with me on that point. Hospitals have changed. Since the 1962 hospital plan, there's been a golden age of advances in medicine. We've seen lots of high-tech interventions, things like keyhole surgery, laparoscopic techniques, and these days even more whizzy high-tech stuff. And also lots of new treatments like monoclonal antibodies and so on. So basically, hospitals got more specialised and less generalist. And all of this came at a cost. However, the NHS and advances in standards of living have added years to life for many people, but not always life and good health to those years. And what we're seeing now in the hospital and throughout the NHS is more and more acutely ill people, and it's the acutely ill people who are coming into hospitals, which are the issue that we're facing at the moment. Our hospitals are getting really crowded. One of the reasons for this is the increase we've seen in demand, but it's also in our ability to actually maintain flow, where our beds are really working at full capacity. So something has to change, and we know that the way that we work inside the hospital has to change. Hospitals are not good places to be necessarily, and what we need to aim to do is to get someone seen, treated and out at the earliest opportunity so that they get the opportunity to get back to their normal life and don't lose independence through overlong stays in the hospital setting. We need to get the balance between generalist and specialist care, both inside and outside the hospital right. And also, we need to move away from a disease management approach into a much more relational management and relationship-based approach to patient care. So to do this, we need to think about the workforce. We need to redefine roles and skills and also redefine team structures. And again, that's not just in the hospital, that's how we work across the interface between hospital and primary and community care. And finally, I would say that we have to manage public expectations. The pressure is growing. And we need to help people understand when to use NHS services and how. Thank you. Thank
you very much, Sarah. Can we move on, Peter?
Thank you. Good evening, everyone. I do see some faces in the audience which I've met over the years. It's nice to be here and give the opportunity to give you a flavour and a share of what Healthwatch is about. in the NHS, we, users, carers, patients, people interested in what goes on in our community, there's always been a part for us to engage and communicate with the NHS for its very, very early existence. I mean, some of you may well remember in the very early days there were the hospital boards where patients and users represented working with the professionals. There was that period where we had community health councils, and that was a real engagement of us as a community helping shape our health services. We then had the Links organisation, and we've now got Healthwatch. Healthwatch is just a manifestation, another one, of that wish, that desire for the country, for the state, to involve us as users of those services. I mean, I'm chairman of an organisation called Healthwatch, which I'll explain about in a moment, but actually, as well as being a chairman, everyone, I'm a carer, and I have been a carer for my mother, with my sisters. I have long-term conditions, like maybe some people in the room, and so I'm a recipient of health services. My family, and especially my daughter, is a long-term diabetic, and one of my grandsons who has some particular problems, all receive service from the NHS. So that's my link with what's going on. I've always been involved in representing groups in the community. There have always been issues. And I remember fondly of the big group that was in Malvern when you were fighting for your hospital, the new hospital. And I was kind of alongside that as well, and giving as much moral support as I could. So we, the audience here tonight, in our own kind of ways, are all involved in the NHS. And it is interesting when that national, because that's the one thing I'd want to kind of share with you. Although we, in our communities, at our doctor's surgeries, in the day centre, when we go to hospitals, we receive those services, but the NHS, it's overseen by a national framework. And these very good people that are here with me tonight represent that professional framework. But you can't get away from the fact that what happens to us locally is linked to what happens regionally and what happens nationally. It's not called the NHS for nothing. And we need to understand how all these things interact. Let me turn to Healthwatch then. Healthwatch came about from the latest piece of legislation that we had, which was created the clinical commissioning groups, it created the provider organisation, it created public health going over to the county council. And one of the things it created was Healthwatch. Eyes and ears of the ordinary public, eyes and ears of what's happening to us. Now, everyone in this congregation, this room tonight, has every right individually to raise issues, complain, make compliments. That system is there. But Healthwatch is sitting alongside that system, whereupon if there's any issue that you feel uncomfortable about, not feel you've been fairly heard, listened to, if there's issues that are particular to a community and to a particular medical condition, Healthwatch's job is to make sure the pathway, the way to engage with these professionals at the table is right and proper. So that's what a Healthwatch is set up for. I really do, my organisation, I've got a small organisation, and we will deal with any issue to do with health and social care. But I actually am working for you good people here. I'm representing that public face. So it is my job not to do so much talking and spouting about things. It's about listening. If Healthwatch is anything, we need to listen to our communities, our individuals, the people that are recipients of health and social care, and taking those issues to the decision makers and trying to change it, trying to influence it. And when things go wrong, we have to be brave enough to stand up and say they're wrong. And that's really the role of Healthwatch.
Thank you very much, Peter. So we've heard from the Acute Trust, we've heard from Healthwatch. I'm going to move over to Carl, who is part of the Clinical Commissioning Group.
Good evening, everybody. Is everybody okay at the back? Can you hear us okay? Fine, good. By way of introduction then, I'm Carl Elson, and I'm still just about a GP in Droitwich. I do a day a week there on a Monday. But for the remaining 4 days in the week, I am grandly called the Chief Clinical Officer for South Worcestershire CCG, which basically means I'm the clinical lead, but also I'm a bit like a Chief Executive. I'm the accountable officer for the organisation. Peter's alluded to some of the changes that have taken place over the last 5 or 6 years, and CCGs were the brainchild of Andrew Lansley when he was Minister for Health for the previous, in the previous government. And his aim was really to get more GPs, more clinicians to lead clinical commissioning, And he saw the development of now 211 clinical commissioning groups in the country. Now, Andrew Lansley's aim was that each of those CCGs would truly be led by a GP. Sadly, most GPs were a bit anxious about that, giving up the day job and taking on that responsibility. So at the last count, only 40 clinical commissioning groups across the country are, I suppose, clinically led, of which South Worcestershire is one. Within the county of Worcestershire, there are 3 CCGs. South Worcestershire's is the largest. It covers about 300,000 patients and covers the entire south of the county. Our geographical area is about 44 miles across. It stretches all the way to Tenbury in the west and down to Breedon and Broadway in the east. And we've kept broadly 4 localities, of which Malvern is in our Pershore, Upton and Malvern locality within that organisation. We have an annual budget of some £380 million. So what happens actually then? So you pay taxes, your taxes go to the government gives them to the Department of Health, and the Department of Health gives them back to me. And so what I actually am are your personal shopper. We are your personal shoppers for healthcare. I am entrusted with your money, and you hopefully trust me and my colleagues to spend that money wisely. Most of it goes to my colleagues on the stage here to deliver services on your behalf. Our main providers of acute care are Sarah's Hospital, Worcestershire Acute, and our main providers of community and mental health services are Stephen's Trust, the Health and Care Trust. But as your personal shopper, I am responsible for monitoring the quality and the safety of the services that are delivered, and this has really gone up several notches over the last 4 or 5 years since the Francis report. We were asked to do a sort of little brief summary now about the challenges that we face, and it's a similar challenges across all of the people, for all of us sitting on this stage really. One of the things that will come across tonight is how actually when you look at the NHS, it's very complex. It's made up of lots of constituent bits that most people most of the time don't realise. They just see the 3 letters NHS as being a sort of homogenous organisation. Now the good news is, despite our separate silos, we are really trying to work collectively, and there's been a major change really over the last 4 or 5 years in that respect. And that's reflected in Simon Stevens' 5-year forward view that came out last year, really about radically changing how health is delivered, but less of a top-down way of doing that. It's more of a grassroots, no one-size-fits-all approach, which we are actually now well advancing in Worcestershire generally. So finally then, the challenges that we face, you know what these are. We've got an increasing population. We've got workforce issues. A lot of the skilled staff aren't there anymore. People are choosing alternative careers. The NHS is a victim of its own success in that an increasing number of people now are living longer with increasing numbers of long-term conditions, as Sarah's alluded to. We've also got new challenges, the sort of political and public demand for 7-day access and the challenges that brings. But the big one we all know is the financial challenge that the NHS faces over the next 5 years, and we were also asked to think where we'd be in 2020. And one of the things that came out from the 5-year forward view is if we continue with the demand that we currently have without any real change in finances, there will be a £30 billion gap in that, the difference between those two in 2021, which is a stark fact when you think that the NHS budget is only £115 billion a year. So that's the scale of the challenge that we face on this stage. Thank you.
Thank you very much, Carl. And last but not least.
Thank you and good evening. I work for the Community Mental Health Trust, and as was said by my background, I'm a mental health nurse by background. So probably we have similar challenges to the others, so I won't repeat those, but I've got probably a couple of other observations that I would add. I started off as a user of the NHS, so my first interaction would have been, being born, and I have probably one of those long-term conditions that Carl described in that I'm asthmatic, so I use it regularly. I then trained in it, so I'm absolutely passionate and care deeply about it. And I think one thing I would say, because it's easy when you see the media and you see a lot of the stories about the NHS, even on evidence comparing internationally, it still comes out as a fantastic organisation that delivers really good outcomes. In terms of the bits that we provide for Worcestershire as an organisation, so we have 3,500 staff. We have a budget of CARS mainly, that's about 180 million. We provide a vast array of services, and just quickly go through them because it kind of then lends to how complex and how diverse the NHS can be, in that we do community services, so that's district nursing, physio, podiatry, things like that, mental health and learning disabilities, and we provide those alongside the local authority, so we actually have a contract that we provide a lot of services for them, and children's services, and then we have a number of smaller services that you'll probably interact with. Dental services is one. I think for me, an observation I would lead as a challenge, and I'd probably, reflecting on this coming to the debate, was it kind of reminds me a bit of where mental health's been, but it's applying to all the NHS now. Back in the day when the asylums were there, we had a model that was fit for purpose probably at the time. It was what society wanted, and it built it, and it was successful for a number of years as society saw it. But there kind of came a point where that didn't really apply, and the model started to look outdated. So things like, if we look at what's happening now, quality certainly applies when we talk about things like Mid Stafford. We've had some real shocks to the NHS that have really made us question it. You could probably link that to some of the things that were going on in asylums and the way that came out. The money challenge, but I think the bit for me is we had a model of care that was there for a number of years, and the demands that are now put on us by society, all the changes that people have kind of made evident, it's kind of leading us to question, have we got the model right? And I think the next few years will be, we need to radically change that model to meet the demands of the people.
Thank you very much, Stephen. Thank you. We come now to a time where there's going to be a short interval. Okay, I have had the hardest and the most unenviable job of the whole evening of any of you, and I'm still not quite sure which questions we're going for. But I'm going to start in the area of mental health, because as I said, we did have a considerable number of questions. So I guess we're going to be looking to you along the end there, Stephen. But I hope that our other panel members will be able to contribute as well. Tim, Davy, where are you? Would you stand up? And they are rushing to you with a microphone as I speak.
In relation to mental health, and specifically cutbacks in occupational therapy, reablement, have the Commissioners and the NHS Trust agreed on what services should be available to help people recovering from or coping with mental illness on being discharged from hospital?
Thank you very much. So can we go to you first? We're talking about people that have been hospitalised in psychiatric units, yes, and then they are discharged. What support is there for them?
Yeah, there's obviously a wide range of community services. I think the one you particularly mentioned was you mentioned occupational therapy, and is it the reablement type work? Is that the name of it? So across Worcestershire there's a service that we call reablement. It effectively helps to get people back into work or increase their skills. It's not particularly around mental health intervention as such, it's more as looking at mental health in a much wider context, so the role that employment can play, college can play, things like that, and getting people's skills. So we're currently undergoing some work with the Commissioners around what is it we want in that model for Worcestershire. I think we'd all be honest, there are financial constraints to that which are kind of making us have a re-look at it. There are 3 centres that deliver that across Worcestershire, one in the north of the county, one in Worcester, and one fairly close to here, up the road at Powick. They all do things very differently, so what we're trying to engage with over the next month or so is a conversation with the public, the people that use them, the staff, to say, what is it that really works in those individual units? What is it you really value, that if we were going to redesign the service, that's what we've got to keep? I think there's a clear message, because they all do something differently, they're all going to have to change. I think there is a difficult conversation around, everybody is kind of, I think, what we're trying to avoid is everybody gets to almost, I've got to save my unit, it's got to be that. We really want the conversation at this point, which is about what is it about that service as a generic that we need to keep while we've got the financial constraints. I think there's also a conversation that then needs to go, which is if we are reducing things as we are or changing things, then how do we encourage a different model? How do we encourage the public? How do we encourage volunteers? How do we encourage other things? Because there is a lot of those type of services that we've seen elsewhere that actually there are different models of providing that, and it don't have to be NHS-led. They can be social enterprise, they can be volunteer-led. So that's the piece of work that we're doing on now. So in answer to your question, we're probably starting that piece of work before we come up with a model to change anything. So we haven't got a model as yet, because we need to ask people, what is it that you find really valuable about that service?
Carl.
It's just about a couple of points, really. I mean, and I'm sure Peter will contribute in a short while. One of the things that's really changed over the last 18 months, and it sounds like, you know, well, why weren't you always doing this? But we've really introduced the concept of co-production with members of the public and service users. It's not my job or anybody's job here to tell people how services should be delivered. We need to know what the challenges are from an individual patient or client perspective, work with those clients, but be honest about the challenges that we face. You know, money is difficult. And we also have the challenge to try and be equitable and fair to more people across the county, across South Worcestershire. And it is a challenge, but as Stephen said, we're going to fail if we're not bringing people along with us. And as I said, that's the real concept behind co-production.
Okay, Peter, do you want to?
I wanted to share with the meeting the issue about mental health in its broadest sense. I know the question was particularly about, for want of a better word, the sharp end of mental health services. That's very important. I happen to be an independent member of the tribunals that looks at cases, and when we are allowing people to be discharged back in the community, the panel is very keen that that person has the right support. They do need seeing on a daily basis in terms of very basic needs of buying the food, taking the medication, having the confidence to step outside. Now, all that needs a support network. And for those patients that have been sectioned and have come off section and back into the community, I would say to you that there is a framework. It's not a framework I would say is total, but there is a framework. The issue we have, I think, in Worcestershire generally, now in the country, and that is the whole raft of mental health services have really been allowed, again, through the system, through the decisions, to be the kind of poor relation of when money and resources are available. And we're seeing this in very, very big ways. I mean, the annual report on this state of Worcestershire clearly identifies that we'd like the professionals to try and do some more in responding to health, mental health issues, and Carl's quite right. It's a matter of how you kind of share the cake up. But the issue of mental health is very high on the priorities of Worcestershire and of the country. I mean, I think, you know, I think we've identified that if you don't tackle some of the mental health issues, that patient, that client, that family are going to be the next visitor to the GP and to the acute hospital. There's method in that, in terms of if you do something on prevention and build that in, you do sort of, you know, utilise your resources more. But the hard reality, everybody, that is about making tough decisions on resources. Have we got enough community nurses? Have we got enough mental health support? Is the voluntary sector being supported? Got a real good network of supporting mental health groups throughout the county. Redditch is one, they've got one in Malvern, really good, but we've got to give them a chance to actually work. And there's no doubt about it that the cost in human misery, difficulty, suffering, breakdown of families, maybe suicides and everything else, is a real challenge for this country, and it's happening in Western Europe generally, and we cannot let it go. So again, part of Healthwatch's job is to actually try and support the professionals in terms of arguing for the resources, and when we've got a chance to work together, let's do things across the piece to improve the lot. But your question on mental health generally is the right one, and the country have not got an answer to it yet.
Peter, can I just, I'm not going to have this question put, but someone has mentioned a service for people with mental health problems that's going to be closed, and are asking how they might campaign for that to be kept open. So you just talked about voluntary sector and all that sort of thing. Yeah. And I just wonder...
We haven't got the representative of the County Council here, and I work along with County Council colleagues, but that particular point is currently in the public health budget. The public health budget that we have in Worcestershire that we all sort of work from, there's a chunk of money that is in the prevention. It is about homeless, drug abuse, people with mental health issues, learning disability. There's a chunk of money, Mary, that actually is in the prevention chunk.
Can I stop you there and ask Sarah if she wants to contribute to this, or...
Well, I mean, obviously, mental health issues impact people and services across the whole of the NHS. And just because we're an acute hospital that deals with the emergencies doesn't mean that we've got issues as well about how we can ensure people with mental health problems who come into the hospital receive the whole package of care that they need, and that they are supported throughout their stay and their transfer back into the community. But it's a difficult area for us. I think it's a difficult area for us all in ensuring that we can provide that support consistently.
Thank you very much. Thank you. Does that answer your question? Yeah, okay. I'm going to move on now to Kathy, who asked a question about social prescribing. So I'm going to, if you could wait for the microphone. And I'm going to go to Carl first with this question.
I was asking a question about social prescribing, which is seen as a current way to link medical health and social care through GP practices. But my experience is that it's really difficult to get GPs actively on board with it. And I wondered about your thoughts on that. Do you believe that GPs are really committed to social prescribing? And how do we make it more effective?
Could you give me an example of the areas you're thinking about with
social prescribing in terms of prescribing social care and support for people. I work for a charity that is actually involved in the social prescribing model, where GPs who have patients who are regularly coming to their surgery, who don't the GP can't do any more than they're currently doing in terms of medical support, but they recognise perhaps that a person has anxiety, stress, depression, those kind of things. And the social prescribing model is in terms of the GP identifying that and saying, well, that's not something I can deal with. I can deal with medical stuff, but actually I can signpost you or refer you to an organisation that can. And actually, the GP practices fund that support rather than assuming it's a voluntary sector and free support.
I mean, it's an interesting example of what I think is the direction of travel now for health and social care, and it's much more about integration. I think one of the constraints of being a GP is you're expected to know a lot about a lot, and quite often we don't, and we're very poor, to be honest, at signposting people. And across South Worcestershire, primary care is working alongside Stephen's organisation and social care, and also the voluntary sector, to try and create a more wraparound service for the frail and the vulnerable, so that it's not an individual who's supposed to know everything about that, but somebody in that team will know and take over the sort of responsibility for signposting. And we're thinking about like the care navigator type role. So we have what we're doing at the moment is we're identifying the severely frail who we know get a bad service if they're admitted to hospital, for example, and the aim being to try and keep them out of hospital or only in hospital for a shorter period of time. And the team who would support that individual would know all of the relevant bits of social prescribing or social care or support in a wraparound way. But it's something that we are working on, but I don't think most GPs most of the time would absolutely be honest about knowing where to point people, because there's too much information. But we are getting around that by hopefully having, as I say, experts within localities who can do that on behalf of those patients.
Thank you, Carl. Anybody else wish to? Thank you, Susan.
I think the other point that you raised about not just seeing it as a voluntary, and I think where organisations like ours come in. So we're doing some really interesting work at Birmingham around young people's mental health, so 0 to 25 service. That was interesting because there's 3 or 4 providers, of which we're one, where we, in the contract, committed quite a significant resource to the voluntary sector, and we worked through how we would coordinate that across Birmingham. So I think, as well as Carl's saying for the GPs and in his commissioning role, I think as providers we've got to be a lot more open. I think we're starting to signal that actually we know where our bits are, what we're good at, and we've got to encourage that voluntary sector and all those other organisations to do that bit, because that actually takes the demand off us as well, so it's kind of a win-win for everybody.
The other thing you may not be aware of is that, and maybe Peter can contribute in a minute, about social isolation is a really important problem that we've identified, and I think we're one of the first in the country, aren't we, Peter, to put a bid through to work collectively to overcome that, but Peter will know more details than I will.
Would you like to?
I know the word, Kathy, has been used, social prescribing. I kind of tend to say us as users, carers and patients, getting the best out of the community in the voluntary sector that we've got. Very often has to be led by professionals. But you cannot run a sophisticated health and social care system nowhere in the Western world, certainly not in this country, unless you do engage with the voluntary sector and users, organisations like the church. We have to tackle the problems that we've got as a collective and across. And it is interesting, in South Worcestershire, and Carl heads up South Worcestershire, we've got this opportunity through the Prime Minister's Challenge Fund, which is bringing in a little bit of resources to actually see how we could be more effective in sharing those services. So when I go and speak to Age UK or Onside or the Alzheimer's Society, I mean, all these organisations are in our communities. What we've got to do together is to get the best out of them, and to do that is kind of working together, which, you know, we're trying to do in this part of Worcestershire. Not pretending it's successful yet, and we've got some way to go. But the answer is to tap into our own resources as well as those of the professionals.
Thank you, Sarah.
I was going to, it comes back to what I said at the beginning in my introduction, really, that the frail elderly patients who are occupying many of our hospital beds, not through, fault of their own, and it's not the right place for them to be. If we could work, we need to sort of be able to wrap services around those patients so that if they do touch the hospital, there's a very rapid way of ensuring that they are then supported to return to their usual standard of living and independence. And the danger we've got at the moment is that people get stuck in the hospital system and lose that level of dependence and become more dependent on the services that we provide while they're in beds in hospitals. So I think this is an issue that runs across the whole of the pathway from primary into hospital. And I would also say that we had some really good examples last winter. Last winter was a really, really bad winter for the health service in terms of our ability to cope with the demands on services right across the board. But we had some really sort of good examples of how we can work together. For example, sometimes the simplest thing was needed to get someone home, and that was someone to go and do a bit of shopping, or someone to go and make sure the heating was switched on. And we had some really good work with the voluntary sector, with the third sector around that, just helping us get people out of hospital into a safe environment. And it wasn't that we needed to do anything particularly complex. It was things as simple as that.
Thank you. Again, I'm not going to invite the questioners, but a number of people did talk about this interface between health and social care and the drawing together, even in a budgetary sense. And people are asking if this is something that you would be looking to and would welcome.
It's actually happening, folks. I mean, I know it's a long process, but I mean, it's working. I mean, I sit at meetings with these people around the table, and there is a dialogue, there is an attempt to join those services up, which is, from my point of view, it's a move forward.
Thank you very much. Has that answered your question?
Resources have also been put into the voluntary sector, because I think the sector in Worcestershire is itself struggling. We're mentioned everywhere. Everybody talks about how the voluntary sector can contribute. The voluntary sector, however, has its own pressures in the current climate. and we cannot generate all the money from trusts and funds. We do need resources to do effective high-quality service using volunteers and community members. And I'm sorry I couldn't have an opportunity to let that go, really.
I'll just follow up. One of the challenges that we have as commissioners is the breadth of voluntary services out there, and it's how do we access sort of a representation of all of the voluntary sector groups. You know, we have 1 or 2 people who attend meetings. I find it very hard. Do they truly represent the voluntary sector? Because there are at least 1,000 voluntary sector organisations, aren't there, across South Worcestershire? I don't know what you're... Yeah, but you... Yeah.
I think it is an issue.
Yeah.
And I'll talk to you privately about that afterwards. But,
I just worry that we miss a trick, you know. It is complicated and it is complex, but I'm just fearful that we may be missing some benefits really by not encapsulating all of the skills that are out there.
I think that's the way forward. That's something that needs to be looked at.
Yeah.
I'm going to change direction now. David Borton, would you like to ask your question?
The NHS, free at the point of delivery. Is even this concept, which is a founding principle of the NHS, up for discussion in the future changes? Thank you.
Right.
We can all have a go, can't we?
I was going to say there's a beat of silence on the panel, but who's going to start?
I might start.
Go on then, Carl. Yep.
We're fighting over answering this one, so... I think that's really the crux of the next 5 years, really, isn't it? You know, at the moment, it's a constitutional right that NHS care is free at the point of entry, unlike social care, which, as you know, is means tested. I think at the moment we're hanging out the hope that the 5-year forward view will generate the savings for that to still be the case in 4 or 5 years' time. But as I said earlier, the scale of the challenge is massive. You know, effectively, the NHS has got to save £30 billion over the next 5 years on a budget which is only just short of £120 billion a year. So, there's a lot of hard work to be done in order to maintain the free at the point of contact.
Thank you. Who's next?
I don't mind.
Stephen, thank you.
I think that, I suppose where I go with this, just my view, is I think there needs to be a debate kind of nationally about what is funded by the NHS and what isn't. So I don't think it'll be so much what's free at the point of access, because I think that's a principle that I think the population, us working in it, do hold dear to that. I think it will be more about, we know we've got financial challenges, the NHS budget has grown significantly. What is it that actually, when we take a look back and have a conversation with the population, do we think there are other ways that we need to pick that up, and actually the NHS shouldn't be paying for that? And they are going to be really difficult services. I think they are difficult services and difficult conversations to have, because obviously every service the NHS provides is dear to somebody. It's just when you take it as a whole, I think we are going to have to kind of see a shift over the next few years to meet the financial challenge.
Personally, I think if we started to try and introduce charges and costs for using services, we'll just create a whole bureaucracy around that. It would be completely unmanageable. Funding our NHS services through taxation is actually a very, very efficient way of doing it. But what I think would be of value is if we were able to demonstrate to the public and patients about how much it costs to use the NHS, just raise awareness of, for example, how much it costs if an appointment is missed, or how much it costs if for some particular services. We know that within the hospital, if we make our staff more aware of the cost of bandages, the cost of equipment and so on, that they use it much more carefully. So I don't personally, as I say, think the answer would be to introduce charges. I think that would be unmanageable, but more awareness of for the public as consumers of NHS services about how much they are consuming, I think would be a very valuable thing to do.
Thank you.
I attended the national NHS AGM down in London last week, and the chief executive of the NHS, the man responsible, and his team, Simon Stevens, in a public debate was very honest, I think, and upfront, and he was saying, in paraphrasing, look, if you want me to run an NHS, largest organisation in Europe, most expensive organisation we've got, to the government, you've got to be prepared to resource it in the appropriate way. If not, tell me and my board, what I have got, and then we'll balance it. There's a bit of an honesty about, and I think part of that debate about what we want as a public is about being honest about that. And I would say to you, that is being done at a very high level. If there were two documents I would ask sort of members of the public to be aware of about our NHS, it is that one which has been mentioned, the 5-year forward. That is the plan for this country, this nation, on the service that you and I are going to expect over the particular coming years. The man responsible and his board of directors is very clear that will change services for us for the better. But he has also made the point at a cost, which is right and proper. Then the other thing I'd say to you running alongside is please don't forget our rights. NHS Constitution, that document which I carry with me everywhere, gives you and I the rights to information, to engage with these good people, to have an opinion, to actually, work with the system. We don't do enough of it in this country, we don't do enough of it in Western Europe, but we have got our rights, and part of it is actually pushing some of those things, knowing when to raise things, knowing when to speak up. And so with the knowledge of these documents, maybe we can tackle these wicked questions. From my point of view, it's a personal view, not Healthwatch's view. We actually have not got enough resources to allow these people to do their job properly. Now that comes down to us as a nation to deciding what we may want to do. In 2 papers last week, the Telegraph in its leader column and in the Guardian, it made it very clear the amount of money we as a nation spend on our health service and care services is the lowest in Europe. That's what you've got to move. If you want to move that, you then give the nurses, the consultants, the doctors a better chance. But that's a very, very powerful argument. The country are not quite ready to do that. But you do have to understand that the reason why you get a better service in Holland, in France, in Germany, in Spain, and in the Scandinavian countries is they spend more of their money on their services. That's a real difficult one. And I'm not being political, because I'm just saying that's a real difficult decision we have to face.
Well, you've just led me very nicely into the next question. Helen, would you like to ask your question? I've got it here for you.
My question is, could we or should we remove the NHS from short-term political control?
Up to you, Peter.
This is Peter Pinfield speaking, not in case there's a member from the press here. Of course we should. I really believe that there are certain wicked issues in our country and nation. For me, environment's one of them. Second one is how I treat my elderly people and elderly population, and it's the kind of health and needs of the nation. Those should be removed from the political equation. The changes that constantly happen every 4 years, another set of rules and another change. But that's got to come from the nation. That's got to come from the nation. You mean, I think people have got to say it needs to be done differently. It's a personal view, and every time we have a new minister, every time we have a new change, it's another real big burden for these people to actually do things. And it can't be the way we do it. Most of the Western Europe and Western world doesn't do it like that. They agree the budget, they agree the policies, and they let people get on with it. And I think that would be a better model for us. Whether we'll achieve that, I wouldn't like to guess, but I'd like to have it there. It's my contribution. Peter Pinfield, private view.
Carl, from the clinical commissioning group's point of view, I mean, that's the new system.
Coincidentally, the person who invented the new system, Andrew Lansley, well, I heard him talk about 4 years ago when he was bringing about these changes, and he said then his aim was to remove the NHS from political interference. Now, he meant that, didn't he, Peter, at the time? I think we may have been there together. But I think we can't let the politicians off having the debate that we've just discussed previously. You know, what do people want from the NHS? Define it, and then allow us to take it over, I suppose. But don't blame us now for that difficult discussion. I think we need to have that separately.
Question. Stephen?
I think that's a brilliant question, because I personally am really torn on it. The easy answer would be to say, yes, I think it should be separate. The question I'm left with, though, is who's it accountable to then, and how is it accountable? We are a tax-funded system, and the democracy that we've got is we elect people on that mandate. Health is probably one of the most important issues. So how can we not give that to the politicians to hold us to account for and set that as an agenda? So it sounds really attractive, but I haven't really seen the alternative about how would you hold the NHS to account and people like me for what it does and what it decides it's going to spend its money on and how it's going to deliver. So I guess I am really stuck on it, but I do lean more towards we have to be accountable. We've got a democratic system. That's the one I would stick with.
Sarah.
I think the first sort of shoots of any change along those lines, and they are very, very, very early shoots, I think, is the devolution debate. Don't mean devolution for Scotland and Wales. I mean, some of the big cities, Manchester, for example, has gone down the devolution route, and they are the only one, I think, to my knowledge so far, that have actually tried to bring health into that debate. So you're getting the accountability through local political arrangements rather than, and not necessarily political arrangements. I think they're inventing new bodies who can oversee some of these devolution developments. But I think that is very, very early days, and certainly discussions around health joining in the devolution debate are few and far between.
Okay, Helen, I wonder if you want to respond to that, or if anybody else does even.
I thank you for your honesty, really. It's refreshing to hear an answer from each of you from the heart, really. So thank you.
Thank you. I'm going to go back to, if I can find the question. As I say, we had a lot of questions about mental health, and I now can't find the one I particularly wanted to be asked. Somebody wrote on their question, here it is Gillian Butler. Would you like to ask your question? Thank you, Gillian.
As someone with a psychotherapy background, I was interested to hear that at least 20% of young people who are recommended by their GPs for mental health support do not qualify for help. Can the panel comment on this? How does it work in Worcestershire?
Thank you. And before I invite panel members to answer that question, I would say there have been other questions that have been very similar, in the sense that we're all being made very much aware of the increase in mental health problems. The Times has been running a major campaign on mental health in young people. Excuse me. And basically people are asking that same question. How is the NHS going to meet this need? So I'm looking to my right first, Stephen.
Okay, so I can explain how it works in Worcestershire. So my trust runs the Child and Adolescent Mental Health Services, which is kind of I'd probably say that the one thing we're really good at is making things sound exceptionally complicated, and I am really trying hard not to do that, and I am really trying hard not to use any acronyms, so forgive me. You're more than welcome to throw stuff at me if I do. So we're the kind of level above, I would say, primary care GPs. So we do see an increase in pressure around young people's mental health. I think the bit that's sometimes lost in it is, and it probably links to some of the questions earlier, is I think the gap for me is what's there before that, the prevention element of it that people can help with. So the way that we're trying to tackle that is we're fortunate in Worcestershire in that for us as a trust, so we provide health visiting, school nurse and a range of services like that. So that integration that we talk about, we are trying to do that. We are doing a lot of work around that with our specialist practitioners and also those that see a lot of children, so school health nursing, who actually probably see the first signs of something. And actually, what we do know from mental health, and probably you'll know yourself, is the earlier you can intervene, you don't need to escalate it up, then you can usually put something around people, so hopefully they don't need to go through. So that's how we're tackling it. We are aware nationally this is a big issue, and I think a lot of these services are coming under increasing pressure. We do work closely with the local authority. The local authority have previously invested quite a lot in early help. So again, the same principles. So I think we've got a long way to go with it. Well, I wouldn't say we've got it perfect and we've got all the answers, but I think one of them is how can we make other services more aware of the needs of children and young people, get early help as quick as possible, and then we've got specialist practitioners who can support that and look after those really vulnerable children that are there and have needs.
As a GP, do you want to... can I just ask that that was a specific question about young people, but can I ask that it's widened in your answers to cover the fact that overall each generation suffers a higher degree of mental ill health?
I mean, this it's a recurring theme tonight, really. I think mental health services in children is probably a victim of the fragmentation about how it's delivered. You think it is incredibly, probably children's services are probably one of the most complex areas because little bits of the service are commissioned by lots of different organisations. So local authority, public health within local authority, I commission a bit, other specialised services make, it is complicated. And I think it's an example of how we're starting to break down those barriers by encouraging partner organisations to deliver a seamless service in an alliance type approach. And there are numerous other examples of that, but I think it is bad. It is going to improve, and the reason it's going to improve is because we will have to break down the barriers between organisations and make it a seamless service.
Thank you, Carl. Do you want to anything?
I wanted to mention that you good people here can actually help us build up a story of what is happening in Worcestershire. One of the things I think the staff have put on is our little kind of contact sheet, because don't forget, we're the eyes and ears of you. So if there are any issues regarding people on that mental health area not getting services or finding a difficulty, it's about gathering some facts. I can't persuade Carl and his team or anybody to change something unless we have some sort of factual evidence, because that's what people respond to. So if you've got any examples of waiting times and poor services, please let us know anonymously, because we're not naming people. But it does help us build up an argument, not just for Carl, but for national stuff, because I think Mary's right. There is a national issue about mental health, and in Worcestershire, particularly for younger people. It is, when we look at the data that we currently collect, it is very clear that many young people, 5th and 6th formers, early universities, are having mental health issues, and they're not able to get through the system because of demand, because of everything else. But unless we actually make an argument for our own people in our community, we're not going to be able to give people like Carl the evidence to actually change things. So there is a plea for you to sort of share those experiences with us, because it is important.
Thank you. Do you want to respond to that?
Well, I was just saying, would you be happy for us to get together some data on that, some real information? Yep.
As Peter said, sometimes we don't know everything. Obviously, we don't know everything about everything, and really, knowledge is really important to us as commissioners.
Yeah. Yes. All right. Thank you very much.
Thank you. Does anybody else wish to add anything to that? This very big.
Yeah, I've been a volunteer with Childline for 29 years, and when I started 29 years ago, I might get one child talking about self-harm or anxiety or feeling suicidal every 2 or 3 months. Now I get several every single shift. That's how it's changed. And what we're doing, basically, is we're the finger in the dike. And really, it is getting very, very serious. I talk to lots of young people who've been waiting 9 months for a CAMS appointment, or who have had one appointment, been given a group therapy session that wasn't really appropriate for them and sent on their way. And it really is very, very serious. We have an epidemic now of self-harm and of suicidal young people. And I'm very, very concerned about it.
Thank you very much. June Bagley. Have I pronounced that right? June? Yeah, is that June there? Thank you.
Thank you. Do you envisage that a further increase on the outsourcing of care to private and multinational, I don't put them together, companies, even if TTIP is imposed? TTIP? Transatlantic Trade and Investment Partnership, that's going to probably to be agreed at the EU in December, which will allow the impoverished private companies in America to actually come to Britain and help us provide a health service.
Who would like to start with this one?
Well, I'll start.
Go on then, Sarah.
I think it's interesting that you single out America because obviously it's a transatlantic agreement. We've made lots of comparisons of the American healthcare system to the UK system, and there are pockets, I think, where there's some really good stuff that's evolved in the US system that we've tried to introduce over here, and that is largely captured in the 5-year forward view, the document that Peter held up, that we're actually trying to do some of that work at scale and at pace now. But I can't see how other aspects of the American model of healthcare would translate very effectively to this country. I think so I suppose I'm trying to say it may feel like it's a massive threat, but so far our experience of working with our partners across the Atlantic on health issues is that we've got a little bit to learn from each other, but there isn't a huge scale comparison that we can draw.
Thank you. Thank you, Carl.
You're shaking your head there, Alex. Just to echo the point there, I think there are good examples of good practice from America. I know we're not, the Integrated Care Organisation, which is actually delivered in parts of America, is very much what the end of the 5-year forward view is looking towards, where we have a truly integrated care organisation. It's seamless. It encompasses primary care, secondary care, health and care trust care, all under one organisational banner. To reassure you, obviously as a commissioner, we have to go through due process when we procure services. And I think there is less appetite now from the private sector to come forward because there isn't a lot of money in providing health. And the procurements we're currently doing tend to be more coming forward from more established traditional NHS providers, quite often forming alliances with other organisations. I see people shaking their head, but that's my experience locally. It's unusual, I think, isn't it, Stephen, for us to get private providers now coming forward in the numbers that potentially we may have expected 5 or 10 years ago.
Would somebody who was shaking their head like to comment?
Yes, in the past I've been a senior manager in the NHS, and way before we had this threat, and the amount of man-hours it takes to bring together, to manage the top of the umbrella, the outsourced agencies is very great, and there hasn't really been any research into the amount of hours, the management hours that outsourcing and bringing in different models even, as you've said, how much it costs the service, how much it costs the taxpayer.
Do you mean in the procurement process? You mean in how these organisations bid, or in the actual management of those contracts?
It's the reporting, the paperwork, all the things that are non-clinical.
Right.
You have multi-organisations under one umbrella. It costs a lot of effort.
I think the future direction of how services will be provided is very much, as I've said earlier, it's either an alliance of providers who do it collectively, or you may have a prime contractor, a prime provider who does all of that under the one umbrella. So you have one organisation, it could be your organisation that's overseeing the whole delivery of the service, but underneath that, individual organisations who have expertise in a key area work collectively under that one organisation. It's called prime provision, isn't it, really, where you have a prime contractor. So I, as a commissioner, would have a contract with one provider who then subcontracts certain elements to the service for particular reasons. If they want a bespoke offering, they would manage that contract on behalf of all of them, and I would just be cited on the one contractor, the prime contractor, which actually does simplify the process.
So you're seeking to put June's mind at rest, that it doesn't become a huge bureaucratic...
No, and I think we are constrained by European legislation, obviously, and we can't break that. I think Simon Stevens ideally would like us to be able to use the NHS more for delivery of services without potentially facing legal challenge. It is very difficult for us as commissioners, though, because this is a relatively new area. We've only been going 3 years, and the advice is not watertight, and we tend to play safe. But wherever we can, we make it as simple as possible. We encourage NHS provision, and if there are a multitude of providers, we try and make it as simple as possible and as seamless as possible.
Thank you very much, Carl. Zach, sorry, very, very briefly, because we've come to the end of our time.
Yeah, very brief, and I'm not trying to catch anybody out here, but can I ask how many of the panellists had heard of TTIP and know what the effect of TTIP is?
I had heard of it. I think, I've been interested in the role of the private sector in the NHS for quite a long time. I think, personally, I haven't seen any hugely successful examples of the private sector entering the NHS market, but I think the way that we're looking at changing the models and the way that we provide NHS services, I couldn't say hand on heart that won't create new opportunities. So I think, we haven't seen anything wholesale yet. I think actually, if you look at perhaps making marginal changes where you introduce competition, I think that can definitely improve efficiency. But the future is very uncertain, so I wouldn't rule out that there would be an enhanced role for the private sector in the future.
Is that okay?
I was particularly interested.
Them, don't you?
I do really, yes, please. Especially the CCG,
really.
if you don't mind me picking on you.
I hadn't heard of it, no, to be honest.
I had, and we tried to make a contribution when it was going to the House of Lords to actually minimise it and slow it down unsuccessfully. The vast majority of people that we talk to in Worcestershire want their services, as far as they can, contained within the NHS family in this country, our hospitals, our GPs, our day centres.
Thank you, Peter. Stephen?
So I wasn't aware of it.
We are coming very much to an end now. Such has been your enthusiasm that we've overrun by a few minutes. But it just falls to me to say thank you very much for a wonderful, wide range of questions and for the superb answers that we've had. And just to reiterate that all of your questions will be read, and I know the panel will want to see them all and will take back some of the thoughts. So I now hand over to Alison.